Welcome everyone this evening to the Pandemic Resilient Cities Conference organized by Emergency Architecture and Human Rights in the frame of the Copenhagen Architecture Festival. This evening we will get an insight into the effects of a pandemic in the urban, but also of the intricate relations of the built environment with the social dynamics of health and public spaces. With us we have Josephine Chow. Did I say it well or kind of? The co-founder and director of Copenhagen Architecture Festival. Michele Di Marco, CEO of Emergency Architecture and Human Rights, Luca Fontana, toxicologist and epidemiologist from the World Health Organization, and Dr. Emmanuel Raju, director and co-chair of the Copenhagen Center for Disaster Research at Copenhagen University. Our guest, Jeff Risom, we just talked to him, his son broke a finger, so it's likely that he will come by the end, but we still have to confirm with him because it was a really unexpected situation and we can't really do anything about it, and he can't either. Also, we want to say special thanks to the union team for their support in communications and for allowing us to use the building for the event. And also thanks to UP, who are helping us with the recording of this session, which is gonna be available later on YouTube as well. We're gonna welcome Josephine to the stage. She's gonna briefly give us an introduction to the festival and to the topic. Thank you very much.
Yeah, hello. I'm just beginning is the right way of announcing it. I'm the director of Copenhagen Architecture Festival, and we've been running with events in the cities of Copenhagen, Odense, and Aarhus since Wednesday last week. But in the spring, we went online with a lot of activities, like so many others. And one of the activities we went online with was the first phase of the focus of today, Pandemic Resilient Cities, in collaboration with Emergency Architecture and Human Rights and a think tank based in London called Think Fast, Collective Urban Response to COVID-19, where we invited experts from the built environment together with experts from the health and humanitarian sector to discuss issues related to cities and the pandemic. And I'm just very grateful to collaborate with you on this and to have been invited as co-host of today's event. Thank you, Michele, and thank you, EAHR, on inviting us on this really urgent issue of how we deal with the challenges of the pandemic for our cities of today and tomorrow, of course. Thank you and enjoy. That's it.
Can you hear me? Also on the back? Okay. Well, first of all, thank you, Nico, for the organization of the event. On behalf of Emergency Architecture and Human Rights, and of course, thank you, Josephine, and the Copenhagen Architecture Festival for the kind word. It's always a pleasure to collaborate with you. So today I will do a kind of like a brief introduction related to the history of the relation between the pandemics and outbreaks, disease, and the building environments, the cities, the urbs, the metropolis. So disease and outbreak, as I was just mentioned, has a long relationship, starting from the Athens of the 4th century, continuing with the ants and disease. And the Athens of 4th century, actually, they lost around 2/3 of the population because of a disease. The Ansen disease in the Middle Age, and of course, the Black Death, the bubonic plague that decimates, that kill around 1/3 of the European population, around 25 million people. And that was not just a normal pandemic, it was not just killing people. It would just reframe, change, and transform the political sphere of Europe, the feudalism collapse, the economical system, the economical structure collapse. But also, infrastructurally, they started to change slowly their own cities. So like the medieval, what we see now as the nice medieval age village around Italy, France, Portugal, etc., that's changed also because pandemics. It's also changed because of outbreaks. And of course, I can continue. I can continue with the yellow fever. I can continue with the SARS, arriving until now with the 7 cholera pandemics. And actually, it's not now the 7th one. So it's not still finished. And of course, I can continue with the COVID, what is happening until now. But I want to start with this map. It's a very interesting map. So we'll have an epidemiologist with us talking later on. This is almost at the base of how the epidemiological studies it's now dealing and working. But the interesting thing is that on the 31st of August of the 1854, a cholera pandemic, a wave actually, or cholera pandemic started to strike on London. And exactly on the 31st of August, 1854, like a big outbreak exploded in Soho, in a neighborhood of London. After 10 days, already 500 people died on the 10th of September. And at the end of the outbreak, more than 650. 1/3, after just 1 week, 1/3 of the population of the neighborhood already flew away. It left the neighborhood itself. So what Dr. John Snow did was try to understand what was the reason behind of it. So he took a map and he started to map all the water pump around the neighborhood. And at the same time, he started to map the cases. He started to map which person and where the person was living in the neighborhood that was affected by this cholera, this new disease. And they discover, as you can see here, so each dot, each line, it's one case. So as you can see, like nearby the pump in Broader Street, there is a concentration of cases. So he started to understand and analyze the pump. And they discovered that this pump was connected to a sewage of a pit latrine where somebody living nearby was dumped a nap that was contaminated with cholera. So the whole water system was contaminated. And all these people over there and drinking from the water from this pump were getting cholera. Remember, 500 people died just in 10 days. Of course, we can understand that there is a kind of relation between the infrastructure, between the city, the way people are distributed, and, for example, the water infrastructure. Or in another case, we can see in other disease, a different kind of infrastructure. So this is, in that moment, in London, the establishment of London started to work together with the Department of Health and the Department of Infrastructure. Transformation started at the same times in 2 different departments that never talked together before. And of course, the great thing, always in London, the River Thames, that was becoming the biggest sewage system of the city of London. And in that time, nobody was doing anything until the summer of the 1858, when the parliament was forced to close because it was too smelly. It was impossible to live around the river. So the establishment of London again took one of the biggest decisions of the history of the city. They wanted to transform all the sewage system in the old London, in the old city. Of course, unable to ignore the smell of the river, and considering that at that time smell was connected to disease, the municipalities and the parliaments decides to to transform and rebuild a brick-walled sewage tunnel, a huge infrastructure in the middle of the 19th century. So the problem was that London was growing in terms of number of people, but the infrastructure was not growing in relation with the number of liter of waste sewage that they have to deal with. So I was saying before, they started a huge network of sewage that's actually, it was very interesting because when they finish the construction of the sewage system and the network, they had another cholera outbreak. And the majority of the people that died, they were just in east of London, still the place where didn't arrive the network of the sewage. So again, you can see also in this case, what is the relation of an outbreak, a disease, and at the same time, the building environment. The rethinking of the infrastructure, the rethinking of the city, the transformation of the city and the urbs. And another example, Philadelphia, 1793. Philadelphia at that moment was the capital of the US, and it was the most dense city in the whole nation. But not just this, it was also the hottest one, and the place where people were store rainwater in barrel, the place where the sewage system didn't exist, a place where the water of the sewage was on open air, the perfect environment for the breeding of mosquito. So between August and November of the 1793, Philadelphia was the epicenter of a massive outbreak of yellow fever. And this yellow fever was brought by the sailors with their ships and mosquitoes coming from the Caribbean areas. The city was mainly concentrated around the harbor. And what you see here in red, it's the main concentration of people that died. But at the same time, it's the most dense place of the city. And at the same time was the place where the sailor, while waiting for the goods to move into the city, were living. Basically, there was 10% of the full population of Philadelphia disappeared, just died. So looking at the outbreak, the whole US parliaments and the US government start to think if there was really a good thing that US started to transform in an urban nation or not. And the establishment of Philadelphia started to think and try to discuss if Philadelphia can reinvent themselves or was just a place with no chance for future or for transformation. So the main question that's also similar to the question that we are giving now, can Philadelphia reinvent itself? So what they did in 1795 is basically a transformation of the full city. So they create the first sewage system in the whole nation, and at the same time, they create these famous green spaces that all urban planner and architects are talking at the moment. So they create 5 different parks and green area that can basically absorb the water and reducing the stagnant water into the city. That, as we remember at the beginning, as just said before, was the perfect place for mosquito to breed. This was an extraordinary innovation vision of progressive technology and civitas. And this was an interesting answer and the best answer to all the people that were asking if the US should become an urban nation or not. So it is possible. It was possible because they were rethinking in a different way. Were thinking in a progressive, innovative way. And of course, the last case is Venice, from where the word quarantine is coming from. So quarantine is meaning 40 days. And 40 days was exactly the time that basically the ships, of course, the goods and the people inside of it have to isolate before entering to the city. Why? Because the 14th and 15th century were basically the centuries where the bubonic plagues, the Black Death was contaminated, and the whole Europe, and of course the northeast of Italy. And Venice was extremely vulnerable because it was a trading center. A lot of people were passing through Venice. And this is exactly what's happening also in some of our city, and why some of the city are most affected, for example, for the COVID density, and also at the same times the connectivities. So what they did was to create the first isolation center in the history. So Santa Maria di Nazareth was an island in the lagoon of Venice, and they create basically an isolation center where everyone was obliged to quarantine. And this was not just a time to isolate, was a time to study the people, to try to understand what was the different way of the contagious, was not the different transmission of the diseases in itself. And after 65 years, they create the new Lazzaretto, what they call Lazzaretto Novo, like the new Lazzaretto that was, they call it new just to differentiate from the old one. And the interesting thing that these two highlands, these two treatment center and isolation center, were at the base of the public health system of Venice. So Venice started to transform from one of the worst countries in Europe in relation with the number of deaths for the bubonic plague in one of the example that after was adopted, for example, 300 years later in Philadelphia. The same isolation center, the same typology of isolation center in Philadelphia for a yellow fever was adopted because Venice, or Hill Highlands in New York. But all of this, as it was the case of the parliament in London, and the reason why they stopped and started to think and debate that the river started to be transformed, the sewage system started to be updated and transformed, exactly the same was in Venice. Nobody was doing anything until when the Doge, the head of the Republic of Venice, Giovanni Monsenigo, died. So you can see also that the power and establishment, it's also part of our decision when we are taking decision in general with the pandemics and transformation of cities. So, as I was saying before, these were not just isolation center. They were places where scientists were studying the disease. And it was even more difficult at the beginning, at that period, because the theory of germs appeared just 400 years later. So we just try to understand and looking at patient by patient through the quarantine and isolation area. But let's come to what's happening now. Of course, like everybody know and everybody felt on its own life, like that this year was a radical change in the way we were using our city, we're using our home, we're using like the place of work. So with approximately 90% of the COVID-19 cases reported in urban area, like the cities became one of the most vulnerable area for pandemics. And this is why exactly the same thing that we were saying, national connectivities, but at the same time, the city started to understand that the health crisis is not just staying alone. The health crisis, it's bringing more and more crises into the city. The urban crisis, unemployment, social security, transportation, infrastructure, etc. So what's all of this and all these crises together is bringing is one of the main crises mainly for the vulnerable people that are living into the city. And we will see also later why this. So this crisis has made us reflect also on the way we are living, how we are using our public spaces, how we are using our street that are the main places where also we socialize, where the city is becoming a hubs, where the city is becoming a place of collectivity. So as we saw it before in the different examples that were going through the history that I presented before, now we are also in the case of Philadelphia, now our question is also like, are the city as we know it now are an obsolete system to completely transform? Is this what the COVID-19 pandemic is telling us? Of course, it's also, we have to think about density, the extension of the city. And this is also related to vulnerability of the city in itself that I was mentioned before, will be more affected and neighborhood will be less affected. And normally the neighborhood that will be less affected, more affected, will be the neighborhood that have more density and they have much more vulnerability. So in the recent months, this is not the first time that professionals and the academia, government, municipality are trying to understand what will be the post-COVID city like. And at the same time, like putting together the urban part, building environment and health. What is how like the pandemic is affecting the transformation of cities, how the pandemics is taking out and putting in evidence on the surface, like all the vulnerability of the city in itself. And actually the pandemics, in fact, actually are like a very small virus called SARS-CoV-2, like it put us on to the knees, like it's showing all the vulnerability of the city in itself. And the pandemic, if we wanted to look at the positive time, or the positive way, like the pandemic, it's also give us the opportunity to transform what we were not able to transform in our city before, and to transform and understand the error that we were making in the previous decades. So before the pandemic already, like many were talking about the 15 minutes walk city. And this, of course, like something extremely interesting because you have more equality because you will have system and infrastructure dividing the city in 15-minute walk. So also the space, you will have everything you need in 15-minute walk. But at the same time, this is applicable in city like Copenhagen or in the global north. But what's happening? For example, let's take a city that I know quite well, Santiago in Chile. Like when the people that are the most vulnerable, they are living outside, in the outskirts, in the informal settlements, maybe sometimes, or in a very vulnerable neighborhood, and they have to travel for 2 hours to arrive to clean houses of the rich one. This is not possible, like in that kind of context. Or well, it is possible. It will take decades for this transformation. So what will we do in the same times? At the same time, like, of course, many architects, urban planners are talking about green spaces, are talking about like bike paths. But is this possible in the medium and low income country? It is possible to say to a woman that is have to take a transportation 2 hours far away from their work, public transportation, so train or bus, to bike for 4 or 5 hours to go to their work and 4 or 5 hours to go back. So also this kind of way of thinking that's of the 15 minutes walk, it is possible here. And of course, we'll have great chance to work because if we have an outbreak in this circle, we just isolate this circle and maybe the rest will be okay, maybe. So of course, in addition, the pandemic make visible also the need to improve the standards of our housing, our working spaces, our common spaces, our public spaces, and also in relation with the air quality, indoor air quality, exterior, outside air quality, etc. So just as the hygienist theory influenced the modernist aesthetics, where sanatoriums start to appear, bathrooms start to appear, large green areas start to appear in all our cities. Well, you have one very famous in the Scandinavian country, the sanatorium of Alvar Aalto in Finland, sanatorium of Paimio. And the city started to change because of disease at the time. the tuberculosis. A lot of open air have to be transformed. A lot of space have to be transformed in open air. And use example because like the risk of contagious and contamination because of tuberculosis. And at the same, we are thinking now with the COVID, we are now thinking a different kind of bigger sidewall so we can maintain the social distance, bigger public spaces, bigger balcony. Ventilation is one of the main issues now, for example, in the transformation of building. This was maybe not considered before. So public space and green area have been seen as place like to communicate, share knowledge, share activities, reducing the risk of contagious that the closed spaces added. And the same things we started to talk now. But say this, I also believe that we should go much beyond the hygienist theory. And we have to go much beyond of this pure technical specification. Because one of the main problems, and I think is very clear in this photo, is that the crisis is basing on a structural problem of urban inequality. So basically, I'm sure if we are going to understand the number of cases of COVID on the left side of the photos, we will have much more higher number compared to the right one. And what we are doing now, and the opportunity that we are now, that I was talking before, we have the opportunity to change and transform our city that we didn't have before. So it will echo on the future generation. So we have a huge and big responsibility now when we are going to plan the new city, when we're going to transform the city that we are living in. But also I want to introduce something that is like a document that I still thinking it's extremely valuable in this period. And I think, and we think at Emergency Architecture and Human Rights, that it's the North Star where this generation and future generations should look at. That is the Universal Declaration of Human Rights. So the Universal Declaration of Human Rights is at the base of our work at Emerging Architecture and Human Rights, but at the same time, it should be at the base of any urban transformation. Because if we have to bet on cities that are healthier, that are resilient to pandemic, that are more equal, like we cannot create city or create like spaces that just the rich people can afford. So like this should be accessible to everybody. Health facilities should be accessible by everyone. Doesn't matter how much money they have. Like public spaces, green area, health transportation, like social securities, decent work, decent housing system. All of this, it's part of our city. We cannot think of our city without thinking about all this social inequality. So the COVID-19, we can say that it's shining a spotlight on this injustice that we just mentioned. So we have to be brought to our knees by a microscopic virus, as we said before. And the pandemic has demonstrated that the fragility of our world, the fragility of our city. And definitely we can say that inequality, it's basically define our world. And this define our city. So if we're talking about food, healthcare, water and sanitation, education, decent work, I was mentioned before, cannot just be for certain kind of the society. It should be for everyone. And this vision, it's important at the same time now, and it's showing out now as it was 72 years old when the Universal Declaration of Human Rights was written. So beyond learning from the past, what we did also a bit now, we should also thinking how we can imagine the future city. So this connection between the transformation of the city and the reason why our city were transforming in this way, that it's of course because a way of thinking, like the same way we should try to understand which error we did before and why we don't have to do it later on. And we have the opportunity now. So resilience should be at the core and the base of the transformation of our city. And rights, basic human rights, should be at the core and the center of the transformation of our city. And not just the right to the city, but the right to a healthy city. So the narrative of the post-COVID city, we cannot try to understand that just in relation with the contingency. So we also have to, coming from the historical perspective. And so again, this question is coming in, what will post-COVID city be like? Well, I think the post-COVID city will be exactly the same that's of the city that we have now, if we are not discussing the political and economical model, and if we are not discussing and debate the decision-making process. So we cannot have a fair city, a healthy city, a resilient city, if we are not changing, for example, the privatization of social rights and common goods, if we are not radicalized democracy, if we are not recognize that the city should be like equal to everyone, and the city should be accessible by everyone. So the city, it's inherently political and ideological social product. And I think this, we have to be aware when we are dealing with the transformation of city. And we cannot leave this just to technicians. We cannot do this alone. I don't know how many architects and planners there are in the room, but at the same time, we cannot leave this just on the discussion between technicians and politicians. The collectivity should be involved in the transformation of the cities, but also much more a multidisciplinary approach could be done. So like, it's impossible to create a pandemic resilient city, for example, without involving the health sector. It's impossible to recreate and transforming a city without anthropologists. And I will go just try to understand very quickly few projects that we did in relation to reduce the inequality, increase the resilience, but at the same time trying to give the base for a pandemic resilient city. And something that I think is very important to say, that now we are focusing on the questions. Sorry, now we are focused on the answer of the question that we made before. But I think we should reframe the question itself. And what we are trying to do at the Emerging Architecture and Human Rights is, together with our partners and together with the community we are working with, we are trying to working on this kind of questions. Why the question that was done before is wrong. What we have to consider when we are considering the future of pandemic resilient city. So this was a project that we did together. It's a green open library, a project we did together with the community in Sudan, and the idea was basically on the right to education for everyone. So not everyone, for example, has a CPR number in Copenhagen or in Denmark. So how we can give access and equal access to library, for example. So we did this also to try to involve the local community, to try to involve the library, to try to involve and think how the open space could be used also in a different way. And this is the snail band for 100 people, how we can rethink in public space, how we can rethink in spaces that basically are accessible by everyone and are also transformed by everyone. This was a collaboration between the rejected asylum seeker and the community, and sponsored by, for example, the Roskilde Festival and the National Theatre. So you can see there are a lot of different level of partnership, a lot of different of engagement, and also the way we are rethinking the public space is not coming from the top to down, as it was in many cases in our city, completely different approach. And this is one of the last projects we did with the local youths, that basically one of the points was to try to understand what was the connection and the friction between the youth and the older people, and in the vulnerable area that now here in Denmark are called ghetto area. I don't like this word, but this is how they call it. And also, like, so the construction of the different public space, thinking already, this was just finished like 2 weeks ago. So you can see that it's an open pavilion. It's an open pavilion because the children and the teenager, they already understood, for example, that ventilation is a key issue. So that they understood that the playgrounds all over Copenhagen started to be closed, and they didn't want their pavilion to be closed. So like how they can rethink in public space, starting for the challenge that we have in our period. And this is a project that will start in 2 weeks, more or less. It's a playground for Bedouin children in the south of Jordan. And what we are doing, what we were requested by the local organization was basically to try to do a playground in the middle of anything. This is just a school and a mosque, and the rest is just a Bedouin tent in the middle of the desert in the south of Jordan. Extremely beautiful places until when you have to live there. So and the problem was here, like how we can create a playground where children can play, but at the same time, they are not stick to each other. So it's a different way of rethinking the space, how we can create circular space that you don't basically face the other child all the time when you are playing or when you are running. And the last project is, we also finished like last week. It's in Castelvecchio Alvisio, in a small medieval village. As I remember at the beginning, we were talking about medieval village in the center of Italy that was almost destroyed by the earthquake 10 years ago in L'Aquila. So what we did is try to involve the community and at the same time the youth on try to how to rehabilitate and give the question how to rehabilitate these spaces and how to do events that are basically allowed by the government because they are pandemic resilient events. So how, and this is an experiment that we'll do also like on the 23rd of October in this place where we are going to celebrate the 5 years of emergency architecture and human rights. So how you can do a pandemic resilience event, how you can, because you cannot share, for example, table and chairs. So how you transform this, how you are rethinking the different use of the space that is very rigid. And this is some of them. But tonight, and I finalize, I ask you to believe that together we can build like healthier city, healthier environment. And there is no organization that can do it alone. There is no professional background that is doing it alone. And one of the reasons that is behind the creation of Tecne. Tecne is a network, a technical network of technical institutions, the WHO departments and university. Together, they are trying to support the WHO, the World Health Organization, in support with the technical background, with technical specification, reports, the Ministry of Health all over the world, different kinds of United Nations agencies, hospitals, and different other kinds of agency in need when there is an outbreak, when there is a pandemic. So what we understood and why, together with Luca and our colleague Anna Silenzi, is we decided to create Tecne within the World Health Organization because we understood that alone, like the architect and the planner cannot deal alone with the transformation of the city. We cannot deal alone with the outbreak that is happening now. And at the same time, the way just the epidemiologist or a certain sector of the WHO was working, it was not possible to do it alone. So this merge between different sectors and this multidisciplinary is at the base of this multi-complexity that we are dealing now. Before, we were just trying to reduce the complexity and simplify things. Now we have to deal with the multi-complexity of the challenge that we are facing. So the last word is that I really would like that after this conference and after the other speaker presentation, like you are going to believe in your own personal collective like experience and personal collective power to change things. Collective and personal power to try to understand how we can transform spaces within our cities, how you can rethink about your home, how you can rethink your working space, how you can rethink public space in general. And we have to work together if we want to do this. We have to think together. We have to deal with the challenge of our world together. There is no way that we can do it alone, like with our own personal background, and there is no way that we can do it alone with our own organization. This is the only way to create cities that are fostering human rights, cities that are resilient to pandemics, and cities that are going to be healthier. So we belong to each other, and we are going to be stick for each other for a bit more centuries. Or we stand together, or we fall apart. Thank you.
For now, we're going to move and we're going to keep going with Luca Fontana, toxicologist and epidemiologist from the World Health Organization. Thank you very much, Luca.
Okay, now we're going to completely change the perspective. Urban health planners is too big for me to get an idea of what Michele was talking about. But already the fact that I'm here because we move a step on a similar direction today. Okay, I'm a toxicologist epidemiologist, and for the last 10 years, I've been working in health emergency, and only with highly infectious pathogens. Ebola, plague, cholera, diphtheria. You mentioned one outbreak, most probably have been there, okay? What we're going to see now is really, we're gonna try to narrow down what Michele was talking about, resilient city, resilient to pandemics from a medical point of view, emergency point of view. So we're gonna go and see an infectious disease isolation, as Michele was calling, or a treatment center. It's a dilemma. We've been calling isolation unit, isolation center, containment facility for the last, 100 years. Lazzaretto, quarantine, where we are going to isolate people, or much to study the patients. Within the last few years, we try to change this approach. We are not isolating people. We're trying to do something more. So far, and I can tell you till 2014, and sometimes today it happened again, treatment center for infectious disease has been designed based on two main topics. One is a public health approach, okay, which starts with protect yourself as a medical staff, your patients, and then your community. And the second point of view was the clinical bedside, the dynamics between the host, the patients, and the virus, and doing your best, our best, for the outcome, the good outcome, the patient survival. Keeping this in mind, briefly, what is the chain of transmission? We need to understand. We talk about resilient city, but resilient to what? Today, everybody know hand washing, physical distancing, ventilation, everybody's breathing with the elbow. But why? What are the reasons behind? Till January, almost nobody knew about infectious disease. And believe me, there have been many. From 1950 up to 2000, we have more than 1,500 new pathogens, as far as we know, and thousands of outbreaks. So the reason why we talk about physical distancing or hand washing is because of this. That's the way a virus, a pathogen spread. The virus, bacteria, where it lives. That can be a human being, can be animals, zoonosis. We have germs get out, how the germs get around, a dirty ends, how the germ get in. Today we know how COVID gets into a people. And that's generate the next sick person where germs stay. And that's It's what makes the disease spreading. What we try to do with the standard precaution, physical distancing, is to break this chain. It's enough to break one chain to stop the spreading of the disease. How it spread? Okay, we can have a direct contact, shaking our hands, for instance, or indirect contact, a dirty surface, airborne, or droplets. I'm not going to explain because I'm sure you read a lot about that. Vector control. Michele was talking about yellow fever in Philadelphia. Vector means that we have a vector transporting, carrying the disease. Mosquitoes is very well known a vector for several diseases. Or vehicle like a waterborne disease. It talks about cholera. In this to decide how we're gonna design infectious disease treatment center, or maybe in future resilient city, we need to know what are the key factors to protect. What are the protective factors? What are the risk factors? And what are the precautions can take to avoid the disease to spread? And here we come about the control measure, okay? How can we control? First, we need to know how the disease spread, how the different disease spread. And then what we can do? We can eliminate the hazard, substitute the hazard, or controlling through engineering control. And we will see what else. Administrative control is changing the way we live, we work, we behave. We do not shake hands anymore. We keep distance from persons. We wash our hands. These are all administrative control. And then we have the personal protective equipment, the PPE, the mask we're used to wear today. These are all control measures. But talking about engineering measure, it's the way we design an infectious disease treatment center. In concrete, this means that we can divide our area, the red one for patients and the green one for the staff. The patient's flow, or the staff flow, or the wayfinding in a hospital. That's our all engineering measure that we can take to try to control the spread of the disease. The furniture and the finishing, deciding which material using for the walls, for the floor, for the ceiling, for my table. That has a huge impact on the way I perform infection prevention and control in my facility. And maybe in our house soon, or in other public space like offices. The problem or the point is that till 2014, the treatment center has been designed with two major objectives. The first one is to prevent diseases to spread. So isolating case, try to contain the disease. You have a new patient, suspected case, confirmed case, doesn't matter, you isolate it immediately. And that's through proper flow, physical and chemical barriers. Like, okay, we have the physical barrier, but we have the chemical as well, like the use of chlorine or alcohol, correct protocol, and train staff. And then the second objective was provide the best care for patients. Comfortable and safe environment, privacy, accessible, transparent to the community. What I'm telling you now is coming from my personal experience. So 100 of infectious disease treatment center, mostly in African country, is where I spent the last 10 years traveling around. It's just now with the COVID that I start working in Europe, for instance. But you will see there are several similar points. How do we translate all this theory into reality? We have nice layout, probably done by architect or engineer, I don't know, but they looks great. If I stick to my principle and I look at the layout, they are great. They allowed a proper flow, they allowed to isolate patients, to contain the disease, they are great. This is on paper, but what is in reality? I mean, how many of you have never been in an infectious, in a color treatment center? The point is that that's on paper or on the manual, that's a color treatment center. It works, it respects all the standard. There is containment wall, there is chlorine, the entry and the exit. It's okay. That's what we have. And we have been treating patients inside. Another one, they propose an hospital ward into a color treatment center. It works. If we take our checklist for the minimum requirement, it works from a structural point of view. And from medical point of view as well, infection prevention and control, it works. Another one, and this is another color treatment center, if we can call it. Then 2014, we had the biggest Ebola outbreaks in history. It started in Guinea, Gekedu, probably end of 2013, and then spread like bushfire through Sierra Leone, through the whole country, Guinea-Conakry, and then moved to Sierra Leone and Liberia. As far as we know, more than 11,000 people died. And that's what we know. Before we were used to have Ebola treatment center of 10 beds, 20 maximum. Here we reach 300 beds in Monrovia, Elva. 300 beds for Ebola patients. And that was only one. We had, I would say, something like 70 Ebola treatment center around the 3 different countries. You can see it didn't change that much. We have a containment, we have fence, double fence, plastic floor everywhere, no window. Let's call it privacy, but it works. I've been working in tens of these Ebola treatment center all around the 3 different countries. The major problem was not designing or running the treatment center, was to have patients inside. Person didn't want to come. Why? I'm sure there are different reasons behind. Fear. It was a new disease for that area. West Africa was the first time in the history that there was an Ebola outbreak reported over there. So it's a known disease. There was very poor communication with the population around the center, in the village, and especially considering the mortality of a disease such Ebola. I mean, 1 people over 2 is not getting out of this center. So imagine I was going in a village seeking for patients. Today I was taking the father, and he was not going back. After 3-4 days going back, picking up the mother, and the mother was not coming back. And then starting with the children's, the neighborhood, and only 50% of people made it back home. Additionally, there was no way to have relative inside. There was no way to have relative praying or seeing the dead body or of their lovely one who passed away in the center. We were too scared of the disease to allow people access to the center. And you think it makes sense. I mean, it's Ebola. Okay? How are we going to send somebody inside? But imagine, if we lose 1 Ebola patient in the community, it might produce 1, 2, 3, 50 new Ebola cases. How can we change this? Yeah, we tried with health promotion. We tried communicating with people. But mistrust, I mean, we have been working for 1 year probably this way, without allowing patients talking with their family while they were hospitalized. And today, back then, I mean, an Ebola patient's average stay in an Ebola treatment center was either few hours or up to 10 days. The time needed to turn negative, and then we discharge and send them back to their community. Today, with the new therapy, they can stay isolated in prison for up to 5 weeks. Yeah, we provide fun so they can talk with their relative, with their family, but that is not enough. We have negationist COVID here, okay? We have full access to all the information we want, but still. So we try to think. We really try to think what could be done to improve. How can we improve this situation? How can we make our treatment center, how can we make our isolation center more treatment center, more accessible to patients, to the community? How can we strengthen the acceptance toward the population? Today we have the COVID pandemics, and everybody is more familiar with infectious disease or transmission chain or being a contact of confirmed cases. Till January, I was struggling to explain to my friends my job. Today, I mean, we're talking about just now, okay, and everybody understand. So today with this, yeah, it changed. We don't have the poor structure we can have in several poor countries. We have more high-tech facility, London, Berlin, Italy. This is Copenhagen. Definitely, much better facility, more high-tech, incredible, better care for patients, no doubt on that. Here, the intensive care mortality rate was one of the lowest, it seems, okay? But again, the treatment center here, not even here, were designed and built around the patients and around the community. Here as well, the family couldn't see their relative who die inside. Several hospitals closed down the access to visitors. So patients has been hospitalized in intensive care and then hopefully moved to different wards for recovery for weeks without having the opportunity to see their family. How is that possible? I don't know here, but in Italy, there's been a big discussion around this. Dead body just piled in the morgue and sent to the graves. No way to pray on that. Here we can maybe discuss about mental health, but what about acceptance? How many people refuse to be hospitalized because they were fearing to die in hospital and not see their relative anymore? Here, okay, in Europe. And that's the same everywhere. We all have the same fear. Dying alone, absolutely, not seeing each other. This is one. And then the impact on public health. Big majority of the healthcare facility everywhere in the world had to shut down essential health service to respond to COVID. And that's because nobody was ready, despite the fact that we knew that the big one was coming. We have been discussing about this pandemic for the last, 100 here. We knew it was going to come, though nobody was ready. Here, just to give you some example, I mean, cancer screening and look, cancer screening in US, Boston, dropped drastically. Delay, access to care delay, still in Boston. access to care to diabetes in Kinshasa, DRC. This is one that's on institutional birth in Nepal. So how many children were born in hospital, in healthcare facility in Nepal during the COVID? Look, 2019, 2020. What do you think that would represent in terms of mortality rate? It would be huge, probably. And that's, again, because we were not ready. Our facility were not designed in a way to be able to surge, increase their capacity. We couldn't maintain care cancer during the COVID. Why? Because we couldn't provide safe environment. I've been in Italy at the beginning of the outbreak to provide support to work in the field. We have hospital where 80% of the healthcare worker got sick. 80% is huge. Yeah, we have better example where we have 6% in a hospital where we have working intensively to change the structure and the way staff is working, visitors are assessing, and the community is living around their care facility. And this is only for COVID, but this is a screenshot I took this morning in ProMed. Today we have 119 alerts for infectious disease around the world. Nobody knows about that. Nobody. Today, in London, they start working on the sewerage system because the parliaments complain about that. In Venice, they built the quarantine, the lazzaretto, because the Doge died, okay? Today, we're talking about resilient city. We're talking about infectious disease treatment center, just because actually two architects, Michele and Anna, and an engineer. It's because I've been working the treatment center I showed you before. And for me, it was insane. How can I improve this? But for the well-being of the patients, to have more acceptance from the community. I want my patients feeling free and welcome when they come to the treatment center. I want his family coming to pay a visit. It should be, a treatment center should be part of the public health system and not a containment. So how can we make this better? How can we improve the situation? Working together. Michele talked about multidisciplinary. Okay, for me, multidisciplinary, it's working with architect, with engineer, with expert on ventilation, with anthropologist, with the community, asking the patients how they want their facility to be. And I'm pretty sure that they don't have understanding on the infection prevention control principle and the structural checklist the treatment center should meet. But they know what they want. They know which kind of food. We have to feed people in treatment center for infectious disease. Which kind of food we want to provide them? When? How many times per day? 1, 2, 3, 4. Coffee? Great. What about green space for Ebola patients that are convalescent? Giving them the opportunity to gather together. They cannot get sick anymore. So how can I enhance their psychological recovery as well? Allowing them to gather together and not making one room self-contained. All this require a multidisciplinary discussion. I don't know how to make it. I know our treatment center should work. I know what are the infection prevention and control strategy that should be implemented there. But how can we translate this medical approach and make it more designed around the person themselves? We tried in the field, and it was in a very simple way. Again, I took a piece of paper with some people around me, and we started designing. And what was the most important for us? Visibility on patients, okay? And so a central corridor for the staff with plexiglass window. It's nothing. It's not rocket science, and we're not going to win the Nobel Prize for this. But it was an incredible game-changing innovation for us. It's allowed to see the patients from outside. I've been working there in Ebola for more than 2 years, and patients could never see my face, never. Today, an Ebola patient can look at a doctor or a nurse and know who is or who is she. We can talk without wearing a mask. And not only that, I can stay closer to my patients, much closer. I can monitor the patients. A simple piece of transparent plastics enhance and push the medical care incredibly. And then, he's a survivor. So he was allowed to stay inside with an Ebola patients, but even from outside, they couldn't touch themselves, but they could see. They could see their patients inside. And then we tried to push it even further, making prefab facility to enhance medical care, but as well to allow contact in between the patients inside and, either the staff or the family through glove box. A couple of plastic gloves sealed in a plastic transparent walls. It's nothing, but huge impact. People were coming to us. We were not looking for patients in the community. They were coming to us just because they knew what was going on inside. They could tell what was happening inside. There was no fear anymore. And that was an incredible change for us. High-tech solution like a transparent plexiglass window, but this is a plague treatment center in Madagascar, because plague is not over. It's not only the Black Plague back in the years. No, plague is something we're dealing with every single year, okay? Madagascar is actually an endemic country. This is a plague treatment center. Under the palms, under the tree, patients could see each other. Visitor could talk with their patients without fear. Again, I'm telling this because that's what we're seeing at ground level. And if we are going one day to work on resilient city, we will have to translate all of this on a much bigger scale. And what it happened is actually that we change from isolating patients from a containment facility to a structure that was built around patient, staff, and community. So the idea is now really to work with different professionals, bringing outside around the same table, different experience, not only technical experience, but people from the community, people that can explain out what are the behavior, the local culture, and the local tradition. And that's why today we create Techne, and that's why we are working all together, doctor, nurse, anthropologist, architect, and engineer, to try to make healthcare facility around the community and not the other way around, having something to contain the patients. Thanks a lot. Thanks for your time.